we will play the patient video, and then you can welcome Dr. Julie. So Dr. Julie will give the presentation, and then we move to question answer session. If the faculties have some question, we'll take that first. Then we can address some of the question from the audiences that will be featuring in the chat box. After that, before going to the panel discussion, we have another 2 minutes video which is on the sickle cell disease, and then we can go for the panel discussion.
So this video will be run in between Julie's talk and the panel discussion, or what Devashish will after the welcome address?
Yes, after the welcome address, the patient video, and like between the Julie's talk and the panel discussion.
Okay, so who's going to start the thing? You are going to start after that?
No. You will take it up. So we are just in the back link to just help everybody out. So Abhishek and team, just if you are ready to go live, give us a countdown of around 15 seconds so that we can start. Ma'am, you are ready, right?
Yeah, I'm ready.
Okay, fine. Your video is not coming. I'm not sure why.
Video I kept off.
Okay, no problem.
I'll on it.
Yes.
When I will start, then I'll on it. Yeah.
Okay. Yeah. So Abhishek, are you ready to go live?
We are ready to go.
So give us a 10 seconds count, and then we can take over.
So I start with 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, go.
We are live now.
Yeah, now it's live. Ma'am, you can go.
Ma'am, you can start.
Okay. Yeah. Good evening, everybody. This is a program webinar on sickle cell disease, and as you all know, this sickle cell disease is a type of hemoglobinopathy which leads to a lot of morbidity, not even morbidity, even mortalities also. So, and the therapy, everything is changing day by day, so that we can do a lot for our sickle cell disease patients now. So today's academic program, we have with us none other than Dr. Julie Cantor. She is a director of Adult Sickle Cell Clinic, University of Alabama, Birmingham, USA. And Dr. Julie Cantor works closely with the American Society of Hematology and the NIH on both advocacy and research. In 2016, Dr. Cantor and her team were awarded one of 8 of the NHABL Sickle Cell Disease Implementation Grant from Sickle Cell Implementation Center. Dr. Cantor served as a PI for over 10 clinical research trials and was a leading enroller on several of those projects. She also developed and ran a statewide program for sickle cell disease. A program she continues to advise. She has authored and co-authored more than 50 articles, book chapters, and abstract. So welcome Dr. Julie to start the sickle cell disease program today. Good evening, Dr. Julie.
Ma'am, we have a video before Dr. Julie to start.
Okay, so we'll have a patient's video, a short video, and after that we'll have the talk of Dr. Julie.
हाय, मेरा नाम है लवली, मैं 20 साल की हूँ और मैं उड़ीसा से हूँ और मुझे सिकल सेल, हम 2 भाई 2 बहन हैं, तो भाई दोनों पॉजिटिव में अच्छे हैं और दोनों बहन को सिकल सेल ब्लड उसके अंदर 4 पॉइंट ही था, इसलिए दीदी गुजर गए। मुझे जब मालूम हुआ 12 थी मेरी उम्र, सिकल सेल हुआ है बोलकर सर।
How are you affected by sickle cell disease?
मैं बार-बार बीमार हो जाती थी। बहुत बार मुझे हेल्थ इश्यूज होता था और पेन्स भी बहुत होते थे जब मेरा तबीयत खराब होता था। तो देखो, जब तो मेरे को स्टार्टिंग जब हुआ था तो बहुत तकलीफ होता था, पूरा जॉइंट्स पेन होता है, ये फुल पेन होता है। हेल्थ इशू होता है कि कहीं हम मर जाने वाले हैं। मेरे पास कुछ वर्क करने को मुझे मन ही नहीं होता था, सांस चढ़ जाती थी। तो ऑक्सीजन लंबा लेते हैं, तो अभी तो भी जान जाएगी ऐसा टाइप लगता है फील। जब उठ के नहीं चल पाते हैं, हम अपनी हालत में नहीं रहते, तो मम्मी ही वॉशरूम को लेके जाती थी मुझे उठा के।
Tell me about a sickle cell crisis.
जॉन्डिस स्टार्ट होने के बाद है ना, आंखें पीले हो गए और बुखार जल्दी आ जाता था, हेडेक फुल होता था। कुछ नहीं है बोलने के लिए, मतलब उतना ही हेल्थ इशू होता है। जब हम सोते हैं तो ऑक्सीजन लंबा लेते हैं, ब्लड इमीडिएटली कम हो जाता है। मतलब अभी वो भी बोलो क्या, लास्ट टाइम पे 4 पॉइंट हो गया था हीमोग्लोबिन। फॉरनली हॉस्पिटल पे आके जब मैं मरने वाली बची।
And what would you say the impact of sickle cell disease has been on you?
मैं बार बार बीमार पड़ जाती थी और मेरा तबीयत बहुत ख़राब हो जाता था। तो पापा है ना, जो मतलब उधार को भी लाके हमें ट्रीटमेंट किया है पापा ने। पापा के बिजनेस में तो सर मेरा जितना पहले तो नहीं मालूम था, तो पूरे बाहर ट्रीटमेंट करते थे तो पूरा अमाउंट ख़त्म हो गया। फिर पापा का शॉप भी बंद कर दिए, तो बहुत मैनेज कर देते थे, पर बहुत ज़्यादा हमने स्ट्रगल किया है सर। और मैं उम्मीद हार चुकी थी कि मैं नहीं जिंदा रहूंगी बोलकर, और उसके बाद मैं उम्मीद नहीं हारी और है ना, जॉब पे स्टार्ट करी मैं जॉब जाना। जब मेरा हेल्थ थोड़ा अच्छा हुआ तो अभी मैं घर भी देख रही हूँ, घर भी मैं ही चलाती हूँ अब।
So you managed to turn it all around.
जब हेल्थ इशू आता है तो नहीं रहता है, ऐसे तबीयत में भी जाके मैं जॉब करके आती हूँ।
If you could say one thing about sickle cell disease that you want other people to know, what would you say?
छोटे बच्चे भी रहने दो, मेरे उम्र के भी रहने दो, मैं अभी जॉब भी करती हूँ। मेरा हेल्थ इतना इश्यूज था, पर अभी कुछ भी नहीं है प्रॉब्लम। घर भी मैं चलाती हूँ, मॉम डैड भाई लोगों को देखती हूँ। ऐसा मत समझो कि हम सिकल सेल है कि हम कुछ भी हम कर लेंगे, आवारा फिरेंगे। ऐसा मत सोचो कि आप लोग ही बहुत टैलेंटेड रहते हो। सिकल सेल लोगों को ज़्यादा ही दिमाग रहता है, बहुत फर्स्ट रैंक में पास होते हैं। थैंक यू।
So we heard from a patient what happened to sickle cell disease and a little bit of their sufferings, what can be shared within this very short time. I think we can go for ahead for the next program and the talk of, everybody is waiting for the talk of Dr. Julie. So I'd request Dr. Julie to start her talk. Welcome, Dr. Julie.
Thank you so very much, and thank you for that introduction. I am very pleased to be here today and to be talking about the future of sickle cell disease, hydroxyurea, and beyond. These are my disclosures, conflicts of interest. So, learning objective. We're going to talk through some real-world cases today. Through these cases, we're going to review the pathophysiology of sickle cell disease, identify the clinical manifestations and complications, review the conventional therapies in sickle cell disease, understand how we are now using novel therapies in sickle cell disease, and then identify some of the unmet needs. We'll explore some of the barriers to care that individuals face. And we're going to start now with pathophysiology. So I start almost every talk with a slide that looks like this, because I think it's so important that we understand that while this was once thought to be a disease of red blood cells alone, and the fact that red blood cells sickle and get stuck in the microvasculature, while true, this is not the entire story of what's truly happening. And in fact, it's far more complicated. When we look on a microvascular level, we learn that the red blood cell is abnormal even before it sickles. It's at risk of hemolysis and breaking down. And by breaking down, it releases free heme. This free heme is very toxic to the endothelium, causing significant inflammation and it acts as a nitric oxide sink. As a result, the blood vessel doesn't have enough residual nitric oxide to function normally. It also provides a stimulus for inflammation, white blood cells, and platelets to stick to the endothelium. And the endothelium develops a Velcro-like texture, which it allows to be more sticky, so that it's not just when the sickled cells stick, but also white cells and platelets that can cause a crisis. So let's start with Joe. Joe is a 42-year-old male with sickle cell disease, hemoglobin SS, and he presents to my clinic. He is presenting referred from our pre-op group because he has an upcoming shoulder replacement surgery. He hasn't seen a hematologist in at least 20 years, and he believes his last transfusion was over 5 years ago. When we look at his vital signs, we notice initially that his oxygen saturation is 92% and that his blood pressure is a little high. At home, he takes hydroxyurea, ibuprofen, and some Tylenol as needed for pain. In addition to the shoulder pain that he experiences daily, he complains of swollen ankles intermittently and thinks maybe these are getting worse, some problems with his vision, and he can no longer drive at night, and some concerns with his memory. So what am I worried about when I first meet Joe? Well, when I look at his vital signs, I'm certainly concerned about his hypoxia, his 92% room air saturation, and his hypertension. Because remember, a blood pressure of 130s over 80s is not normal for someone especially with hemoglobin SS type sickle cell. Plus, he has concerning symptoms. He has swollen ankles. Is this from kidney disease or heart disease or both? The vision issues, is this normal nighttime I'm getting older vision, or is this retinopathy? Concern with his memory. Has he had a silent ischemic event or even a previous overt event? And shoulder pain. We know he has avascular necrosis, but is anything else going on? When we think about the clinical complications in sickle cell disease, we truly have to remember that sickle cell disease is a multi-system illness. It's important because when someone is headed for shoulder surgery, unlike our bone doctor colleagues, we can't just concentrate on the bones, but we have to make sure that they're healthy enough to undergo the surgery from a lung, heart, kidney perspective. We have to consider whether they can be transfused, what type of pain management they will need, what the risk is of acute chest syndrome. There is literally not an organ system that is unaffected by sickle cell disease. And it would take too long to review all of our system complications, but it is important to remember that preventative care can help with many of these issues, and that identifying them can help actually prevent complications. So as we continue in Joe's workup, well, we do a full workup. We did blood work, HIV, and hepatitis C, which we do for anyone who's ever had a transfusion, urinalysis, a urine albumin to creatinine, an echocardiogram, and an EKG. His blood work confirms hemoglobin SS type disease. His hemoglobin is 6.9. The rest of his CBC is unrevealing, and his LDH at baseline is 654. His total billy is 6.9. His direct billy is 0.9, and his creatinine is 1.4. Consistently with that, we see significant proteinuria. We check an albumin to creatinine ratio, and it's greater than 1,000, which is very concerning in anyone, but especially in someone with SS disease. In addition, his echocardiogram shows significant dilation of the left atrium, as well as moderate right atrial dilation. His TR-jet is 3.1, and his right ventricular pressure is 60. His swollen ankles, well, this does look like both kidney and heart disease. His vision, we referred him to retinopathy, and we arranged for an MRI to evaluate his brain. Further, we looked at options for him. We did allow for him to be cleared for surgery, but we required cardiac anesthesia because he seems to have pulmonary hypertension based on his echocardiogram. We also required a preoperative transfusion and ensured that he initiated Lasix to help take the load off his lungs. We finally referred him to ophthalmology for his bilateral proliferative retinopathy. Vaso-occlusive crises, or what we think of as a pain crisis, is sort of the clinically visible part of the vaso-occlusion iceberg. Joe is a perfect example. He had very little pain other than his chronic shoulder pain, so therefore his disease in some ways went undetected or under the water. While under the water, he had significant vaso-occlusion and multicellular adhesion it was resulting in significant chronic damage, inflammation, cell activation, and endothelial damage. So it's important to remember that what we see is just part of the problem, and that looking further beneath the water can reveal many subclinical issues that result in some of the morbidity and mortality of this disease. Moving on to our next case. Jamie is a 21-year-old hemoglobin SS disease. Jamie had very few problems as a child until about 19, when she began to have more pain. She takes folic acid, some pain medicine here and there. But at this point, she's had to drop out of college and she's very frustrated. She's been in the hospital multiple times. When she comes in for her first visit, her vital signs are overall not concerning. Her exam is notable that she's thin, she has yellowing jaundiced eyes, and a mild flow murmur. So what did we do for Jamie? We did the same blood work, urinalysis, and kidney assessments, as well as HIV. We also did additional blood work, which showed us that her urine had no protein like our previous colleague or previous patient. She has slightly elevated white count at baseline of 19.3 and a hemoglobin of 7.5 and an appropriate reticulocyte response. Pain is the hallmark feature of sickle cell disease. It is truly the primary reason that we see patients like Jamie. Pain is often ischemic, secondary to vaso-occlusion, but over the lifetime becomes more and more ubiquitous and present. Sickle cell disease is one of the only conditions that causes ongoing pain throughout the life. So going back to our pathophysiology, we have multiple targets where we can improve people's outcome. Now we understand that if we can stabilize the red cell and prevent it from sickling by altering the hemoglobin, which are possible now through a multitude of ways, perhaps we can prevent some of these downstream complications. If we can perhaps just prevent the hemoglobin from actually polymerizing, or keep it from polymerizing, at least during its passage through the capillaries, that may help prevent complications. The endothelium really is a target organ in sickle cell. So if we can block the abnormal adhesion to the endothelium, we also might be able to prevent some of these complications. Finally, how do we assess the role of platelets, which we know join every inflammatory party? If we can prevent some of the platelet activation, would that lead downstream to preventing inflammation? And what about nitric oxide? Can we improve or replace nitric oxide to help the blood vessels function better? Now that we understand so much more about sickle cell disease, it has allowed us to have a multitude of targets that we can offer new therapies for. This is important because mortality, even in the United States, continues to rise in our young adults. Childhood survival is fantastic, 96 to 98% for all genotypes. However, in 2014, we see most deaths still occurring between 25 and 54. And surveillance data from Georgia and California is very concerning, with a mean age of death at 43 for women and 41 for men. So one of the reasons that we see so many complications in early mortality is the potential complication of a vaso-occlusive crisis. So every acute VOC that's causing severe pain should be assessed. Now, these are not the routine VOCs that patients are going through at home that they are able to manage, but things that are out of the ordinary for those individuals. Each time someone comes in, we evaluate for infection, hypoxia, dehydration, or worse, multi-organ failure syndrome. In rare cases, acute crisis can require IV pain management and hospitalization, but we try to manage them on the outpatient side. Hospitalization can have significant complications. Patients can have acute chest syndrome, both because they get sickling, but also because when in the hospital, they spend more time lying down and not taking deep enough breaths. We know that all patients in the hospital have an increased risk of DVT and thromboembolism that is increased in people with sickle cell. We know that while in the hospital, everyone is at higher risk of infection as well, and that is also true in sickle cell. Secondary infections are a significant concern, as well as bleeding, acute kidney injury from medications, or debilitation from not moving enough. So what do we do for Jamie? We discuss treatment options as Jamie hasn't been taking any preventative disease modifying therapy. We talk about hydroxyurea. We especially explain how hydroxyurea works, how it improves the red cell health and decreases inflammation, and how she actually does have to take it every day. And we devise an individualized pain plan so that when she has mild pain, she knows what to take. When she has moderate pain or severe pain, she knows what to take, and when she should come to the emergency department. We also discuss other newer therapies, L-glutamine, crizanlizumab, voxelotor, and even stem cell transplant. Hydroxyurea remains our mainstay of sickle cell disease therapy. It was the first FDA-approved medication for sickle cell disease. And the MSH study showed that hydroxyurea therapy can improve the clinical course of sickle cell in some adults, especially those with more than 3 crises per year. Hydroxyurea has been shown to increase lifespan in adults. Maximal tolerated hydrea is not necessary for therapeutic effect, and we have seen many places using a fixed low dose with improvement. And we've seen the same with pediatrics with similar safety and efficacy at both preventing hospitalizations and increasing lifespan. So how does hydroxyurea work? Well, we only understand a little bit of how it works truly. One thing we know it does is affects the erythroid progenitors. By stressing the erythroid progenitors, it actually causes a dyserythropoiesis, which is what actually induces fetal hemoglobin production. In addition, it acts as a myeloid precursor suppressor to make less neutrophils and reticulocytes. In addition to those, it also supplies nitric oxide, and this likely helps our blood vessels work better. So it really has 3 main effects. It increases fetal hemoglobin, it suppresses inflammation by suppressing neutrophil and reticulocyte production, and it increases the available nitric oxide. Hydroxyurea, however, is insufficient. Up to 30% of people with sickle cell still have significant vaso-occlusive crises, despite adherence to hydroxyurea therapy. There's also concerns that not everyone tolerates this medication. It's also not 100% effective, and people with SC disease, we really don't understand if it's even useful overall, or if it is, which individuals with SC disease will benefit from hydrea. It does have side effects. It has issues with GI toxicity, but also things that make patients more insecure, like nail darkening or hair loss. And it continues to have this potential for teratogenicity or for fertility issues such as azoospermia that we don't yet completely understand or know how to prevent. So what about L-glutamine? Well, in a phase 3 trial of L-glutamine given at pharmaceutical grade and dose in sickle cell disease, we saw a 25% reduction in the number of pain crises, a 30% lower hospitalization rate, and a significantly reduced number of acute chest syndrome events. This was in the L-glutamine study, published in 2018. It is an amino acid indicated to reduce the acute complications, and the safety is well studied at this point. The trial included patients ages 5 to 58, but the long-term benefits and preventative use of glutamine is still unclear. L-glutamine is also only useful when it is pharmaceutical grade and at therapeutic dose, which is often not available except by prescription. Moving on to Rory. Rory is a 32-year-old with hemoglobin S beta 0 thalassemia. At age 2, Rory had a stroke, leaving her with very mild right hemiparesis. And as a result, she's been continuously followed with hematology and receives erythrocytophoresis or automated blood transfusions every month. And our goal is to maintain a sickle hemoglobin percentage of less than 30%. Rory has required iron chelation with Xjade, but she says it's nasty and doesn't want to take it. And current ferritin is 3,420. And she's very frustrated. She's had these ongoing transfusions. She doesn't like coming in every month and wants to know what else can she do at this point for her sickle cell disease. Again, we do a comprehensive workup. We especially look for red blood cell alloimmunization and antibody formation. We do urine studies for proteinuria. We refer to ophthalmology. We also assess the liver iron concentration, not just with a ferritin, but with a liver MRI. We look at cardiac function, And then we also look at brain MRI and MRA to better understand what type of stroke she had and what her blood vessels look like at this point. We know that blood transfusion is a disease-modifying therapy in sickle cell disease, and that it can prevent acute and chronic complications. We use 3 different methods of doing transfusions. One is a simple transfusion or a top-up. We also do manual exchanges. This is where we withdraw blood through phlebotomy and then give blood back. And we do automated red cell exchanges. There are several complications, unfortunately, of transfusion. The biggest being iron overload, and second, alloimmunization and antibody formation. We also have seen hyperhemolytic transfusion reactions that can actually cause death and transfusion-associated circulatory overload. Simple transfusion, of course, does not remove a patient's hemoglobin S-laden red cells, but only transfuses healthy donor cells. Manual exchange, as I mentioned, is where we remove cells by phlebotomy and then give blood as a simple transfusion afterwards. This does help with iron exchange, but is not nearly as efficient as the automated red blood cell exchange. Automated red cells exchange remove defective red cells, replaced with healthy donor red cells simultaneously, and is iron neutral as well as highly efficient. Iron overload remains a problem that I think we're just beginning to understand in sickle cell disease. In a much earlier study of 141 adults with sickle cell, 7% with iron overload, we saw a strong association between iron overload, hepatic cirrhosis, and myocardial fibrosis. In a subset of 31 autopsies, 7 had significant hepatic iron overload, and of those, 43% had both cirrhosis and myocardial cell iron deposition. We don't completely understand how this iron overload is correlating to death, but we know it is prevalent and contributing to our death in adults with sickle cell. Alloimmunization is an immune response to foreign antigens. It increases the difficulty, as everyone knows, of finding medically necessary compatible red blood cell transfusions, especially in life-threatening situations. As a result, we recommend not just matching at the A and B antigens, but also matching at C, E, and KEL antigens. In the United States, we have a primarily donor population that is Caucasian, and a primary sickle cell disease population that is African American. As a result, there's a difference, and that increases the risk of alloimmunization. In addition, however, it's not just this discrepancy between our donor and recipient. Instead, it's also specific to sickle cell disease. We know that chronic inflammation and immune dysregulation promotes alloimmunization, making it significantly worse in sickle cell compared to other hemoglobinopathies. So we do a comprehensive workup for Rory, and she is in fact well exchanged. Her hemoglobin S is 22%. Her hemoglobin is 9, and her retic count is suppressed as we want it to be at 2.3%. Her ferritin, however, is 4,300, and her liver iron is a very high at 15 milligrams per gram. Her echocardiogram thankfully shows no significant dysfunction. When we look at her brain, we can see an old ischemic infarct on the left, but we also see bilateral intracranial stenosis of the MCAs and significant left-sided stenosis with what we begin to see of moya-moya disease. So what are Rory's next few options for treatment? Well, unfortunately, right now in individuals with significant vascular disease, red blood cell exchange is the only optimal treatment to prevent a secondary stroke. We know that hydroxyurea can prevent stroke if given prior to brain injury, but after a stroke, we also know that transfusion is our optimal option. However, transfusion, perhaps transplant, would be an option for someone like Rory. So she's heard about gene therapy and says, is this possible? We understand that sickle cell is amenable to gene therapy. Sickle cell disease is caused by a mutation in a single gene. So if we could just deliver a functional gene, could this reduce the symptoms of the disease? Gene therapy would prevent the need for a matched donor, would prevent graft versus host disease, and further would make gene therapy, and therefore potentially a cure more available. There are 3 different types of gene therapy being studied: gene addition therapy, gene transfer, and gene editing. Stem cell transplant, however, is another option. It is the only known cure at this time for sickle cell disease. And results of many studies show that transplant from a match-related donor, especially in children, can result in an 85% to 95% chance of cure. But there are risk versus benefit considerations, especially for adults who have accrued more sickle cell-related morbidities with age, such as this patient. And many people don't have a match-related donor. So we're now looking at half-matched or haploidentical transplants as another option for improved outcomes and quality of life in sickle cell disease. Moving on to Ronald. Ronald is a 27-year-old with hemoglobin SC disease. He had done well for many years without a lot of pain. He was on hydroxyurea when he was younger, but he really didn't feel any different, so he stopped taking it after several years. He does take folic acid, he takes intermittent ibuprofen, and tries to avoid the ER whenever possible. However, in the last 4 months, he's had to go to the ER almost every month and has been admitted. And he's frustrated and wants to try something else to decrease the number of pain crises. So what are the unmet needs in sickle cell disease? Well, first, hydroxyurea is not the best medication for everyone. Doesn't work for everyone, and some people can't tolerate it. We see hydroxyurea breakthrough, especially in patients who've been on it for a long time, and they start to continue to have crises. For hemoglobin SC disease, like this patient, there isn't a clear optimal therapy, and hydroxyurea doesn't always work, even less than it does in SS disease. We've discussed iron chelation. We need better options, things that are easier for patients to tolerate. And we need improved medications to treat acute vaso-occlusive crises. While we have improving preventative therapies, when someone has an acute crisis, we have very few options. We also need a universal curative treatment that is available and cost applicable. And we need better organ-specific therapy. We see at least 10% of adults having severe renal disease. So what can we do to prevent that specifically, not just prevent pain? So thinking about the factors we talked about earlier and the targets, we specifically are looking at sickle cell disease options to prevent the vasculopathy or vascular disease. Well, fetal hemoglobin induction, not just with hydroxyurea, but gene therapies and other new agents, can that prevent some of the vascular morbidities that we see? How do we prevent this multicellular adhesion that we know is damaging the endothelium and really resulting in the end organ injury? Oxidative stress from hemolysis and inflammation is also causing endothelial permeability, which is resulting in not just additional pain and swelling, but also end organ disease. Inflammation, this is truly a chronic inflammatory condition, and we know that long-term inflammation is also increasing the scarring of endothelium. We understand that selectins mediate white blood cell adhesion and rolling, and that selectins are expressed on endothelial cells, platelets, and leukocytes. P-selectin and E-selectin mediate rolling and tethering of blood cells to the endothelium. And we also understand that selectins and neutrophils can initiate vaso-occlusion even without a sickled cell. In animal models, where we've disrupted or bred mice that don't have certain selectins, we can actually see an interruption or complete ablation of crises. We've been focusing on P-selectin and E-selectin, as these are the most prevalent and seem to cause the higher amounts during crisis. P-selectin is expressed both on platelets and endothelium, where E-selectin is specifically focused on just the endothelium. Crizanlizumab is one of the agents that we've been studying and know the most about. Sickle cell-related pain crises were what a vaso-occlusive crisis was called during the SUSTAIN study. We understand that P-selectin plays a huge role in sickle cell disease vaso-occlusion. Crizanlizumab is a humanized IgG2 antibody that inhibits P-selectin. The SUSTAIN trial is a phase 2 randomized trial of crizanlizumab compared to placebo in patients who are aged 16 to 65 and who had had at least 2 and not more than 10 crises in the year prior to starting the study. A VOC was defined as pain that required acute care intervention. Patients were randomized to 2.5 mg per kg or 5 mg per kg or placebo. And in patients who were receiving the higher dose of 5 mg per kg, we saw a significant 43.5% reduction in the high-dose crizanlizumab group during the trial. It's also important in that patients were often already taking hydroxyurea. So we looked at individuals both on and off hydroxyurea as part of the trial. Looking at these graphs, the y-axis is the median rate of VOCs per year, and the x-axis is patients who are treated on crizanlizumab or placebo. In this left graph, you can see patients who are already taking hydroxyurea, and quantitatively as well as statistically significantly, a decreased number of crises. Patients who are not taking hydroxyurea over here on the right, you can also see a significant decrease in the number of crises. We also wanted to understand if this drug was effective not just in people with SS disease, but other genotypes. On the left, again, you see people with SS disease, and you can see significant decrease in number of crises during the SUSTAIN trial. On the right, you can see other non-SS genotypes, and again, you can see a significant decrease in the number of crises for patients treated. So for Ronald, we discussed potential therapies. We talk about hydroxyurea, even though he's had it before, glutamine, L-glutamine, and crizanlizumab. Ronald says, I am just not good at taking medicine and wants to try crizanlizumab given intravenously every month. After 3 months, he says, I don't know if this is helping, but he hasn't been to the ER recently. And after 3 more months, he says, I feel the same pain. Well, I feel the same as I did before. But then when he thinks about it, he realizes that he has not been to the hospital at all in the last few months or taken as much pain medicine at home. However, on a day-to-day basis, we sometimes see that patients don't feel any different. And so it wasn't until we presented Ronald with the understanding of his decreased number of crises that he recognized his own improvement. And he says, wow, this must be working, and agrees to continue. So what is our current crizanlizumab experience here? Well, we've had crizanlizumab approved in the United States since November of 2018. And in my institution, we got the approval to initiate using it in January of 2019. Here at UAB, we treat about 500 individuals with sickle cell disease, adults, in my clinic. Our pediatric clinic takes care of about 900. We have about 60% of our patients with SS-type sickle cell, and about 60% of those on hydroxyurea. We have 11% of our total patients on chronic transfusion. And in the last 15 to 18 months, our program has grown substantially. And we went originally from about 370 patients to 500 patients. We have what's called a specialized medical home setup. So we have clinic available 5 days a week, and that includes an infusion center where patients can come for acute pain crises. We have apheresis and transfusion. We have a primary care doctor at the same program, so patients can see both me, the hematologist, as well as a primary care doctor in one visit. We have a pharmacist, we have a case manager and a social worker and specialized nursing staff, and 2 hematologists, myself and my colleague, Dr. Ogunshile, who rotate through. So at the time that I put this presentation together, we'd had 45 patients who'd been prescribed crizanlizumab, and 37 were still receiving it. Overall, patients reported, this is the best thing I have done. This is even better than my hydroxyurea. I can't tell a difference, but my wife notices I'm better. Or, surprisingly, I had 2 different patients tell me their legs hurt less at night. That was important because we have not heard or studied the effect of crizanlizumab on chronic daily pain. Now, I mentioned that not everyone continued taking it. So why did some people stop? 2 people had an infusion reaction. One of those was an increase in pain when they received the medication. This did get better when we slowed the medication and gave Benadryl. But that individual did not want to continue it. Of note, that individual has now gone back to taking it and is actually doing much better. The second person had a true anaphylactic reaction with some shortness of breath, which we know can happen with any medication. 3 people said they had more pain after taking it or felt their pain hadn't improved. One moved, one had transportation issues, and one was fired from our clinic. So what are the barriers to care in sickle cell disease? Well, there's a lot of issues with chronic pain and the perception of addiction. This contributes to issues with racism, frequent visits, because if patients aren't getting the care they need, they get more and more pain or other problems requiring emergency department and acute care visits. There's a clinician and patient knowledge deficit, and there's often a discrepancy in which our patients know more about their disease than the clinicians. And there is a significant amount of stigma that contributes to the chronic pain and perception of addiction. We know there are significant negative attitudes and stigma. These are based often on previous experiences. Patients report being treated rudely or being intentionally delayed, and in fact will sometimes avoid the ER completely. There's a lot of misbelief and distrust that goes both ways. Physicians and providers not trusting or believing patients, and therefore patients not listening or believing doctors. They're often very knowledgeable about their care and their disease. So when a patient comes in and says, I know when I have a severe crisis that hydromorphone, 2 milligrams, works well for me, that can often be mistaken as clearly this patient is a drug abuser in the emergency department. So just educating patients has been insufficient. We have to also educate our colleagues. There's also system level barriers. There are not enough people or providers understanding sickle cell. There's not enough centers that treat sickle cell disease. While sickle cell is more prevalent than hemophilia or cystic fibrosis in the United States combined, when we were actually funded, there were only 10 comprehensive adult sickle cell centers funded. For the record, they're not funded at all anymore. And over 100 each for hemophilia and cystic fibrosis that received federal funding. So even though we have newer medications that may even work better, less than 50% of people who could get these medications are being offered them. So a lot of people have asked, how do we identify with all these new therapies, the right patients for the right therapy? We think a lot about patients' current concerns with their sickle cell disease. What bothers them? What is going to motivate them to feel better? What are their goals for their disease treatment as well as their life goals? I often start off the conversation with a new patient about what they want to achieve, not just as far as their disease, but do they want to work? Do they want to go to school? Do they just want to feel well enough to get up in the morning and take care of their children? How far away do they live from a sickle cell center? How can I help get them to and from? And what other support systems do they have in place? Or how can I help connect them to other potential support? So when we think about a patient like Jamie, an 18-year-old woman, SS disease, she's been to the hospital a lot. 19 visits to the ER in the last 12 months, frequent admissions, last seen by a hematologist at age 13, and hadn't really had any problems till age 17, which we often see this little honeymoon time. When they're younger, she had a gallbladder removal, her tonsils and adenoids out. She'd had acute chest once, but it's been a long time. And she's currently not on disease-modifying therapy. Jamie is somebody that I would sit down and talk to hydroxyurea. We would talk about whether she's willing to take it, and in the case of social media, what she's heard about it. Often we find patients have heard, I won't take it, it'll make me sick, it'll give me cancer, it'll make my hair fall out. And so we have to do re-education. We talk about whether she's able to take a medication every day and remember to take it every day. And if she's willing to do that. If she's not, we may talk about other options like L-glutamine. We find many patients want a natural approach, and L-glutamine is an amino acid and a little more natural. We also then talk about crizanlizumab and other choices. In a different presentation, we have a patient like Loris, a 28-year-old, SC disease, who's also had a significant number of pain crises. For a long time, people with SC disease were thought to have more mild sickle cell. However, we are finding as patients get older, that is not always true, and that in fact, they are having more crises and more complications. She's had AVN of both hips and has had acute chest syndrome, but doesn't really remember it. She was taking hydroxyurea, which she actually did take, but stated it did not help after 2 years of trying. She has a lot of chronic pain in her hips, legs, and sternum, and no history, she reports, of acute chest, but you can find it in her records. So when we see someone like Loris, we know that she's not going to have any buy-in for hydroxyurea. She's already decided it's not going to help. And that may well be true, because we don't understand that hydroxyurea is as effective in SC disease. We also talk about, again, L-glutamine as an option. It does reduce pain crises, but it can be more difficult to take since you have to mix it and drink it right away. She's someone who's probably going to do well with crizanlizumab, somebody who's interested in coming to clinic frequently and wants most of all to get rid of the chronic and frequent pain crises. Finally, we have Ray, a 40-year-old SS-type disease. He's very proactive, very compliant. He's had 4 crises in the last 12 months. He always calls in, lets us know when he's in crisis. He's managed 2 of these at home and 2 had an ER visit. He has had a history of priapism. He also has hypertension, and he does very well taking his medication every day. And he's been on hydroxyurea for the last 3 years. And notice it helps. Well, the first thing we would do in someone like Ray is look at whether the hydroxyurea dose is sufficient or should we increase it. Ray clearly has no issues or concerns with taking medicine. So this is someone we might talk to about L-glutamine, or if he has low hemoglobins, we might talk about voxelotor. Now, it's important to remember that voxelotor thus far has only been proven to increase hemoglobin and not necessarily to decrease crises. So we have a real conversation about the pros and cons. This is someone who's less likely to be interested in crizanlizumab, though I always explain it to everybody and give them options. And we sit together and form a shared treatment plan. And he's someone who often will choose a medication like voxelotor or L-glutamine in addition to hydroxyurea. Finally, Destiny. We have a lot of Destinies in my clinic. Destiny is 21, she has SS disease, and she does not and will not take hydroxyurea. She doesn't want chemotherapy. Nothing you can say to her will tell her differently. She's had only 2 crises in the last 12 months. She almost never comes to the ER. In fact, it's even hard to get her into clinic. Really, Destiny just wants to pretend that she doesn't have sickle cell disease. So we talked to Destiny about how we can help prevent her from having complications, about the importance of frequent, at least twice a year visits so that we can monitor her kidney dysfunction. We can monitor any concerns for retinopathy. We can monitor for any other new issues that arise. Destiny might tell us that her grandmother's on dialysis and that she understands that kidney disease is serious, and that will have her coming into clinic a little bit more. We do talk about hydroxyurea, but as I said, she has already decided she's not taking it. So we talk about other preventative therapies, and most importantly, staying hydrated and drinking water and taking good care of herself, including not smoking marijuana or drinking alcohol. And usually we have a conversation about life balance and care balance and trying to make sure that she can keep herself healthy. So hopefully you feel that we've covered a lot of information today. We've talked about the pathophysiology of sickle cell beyond our red blood cells, the clinical manifestations and complications of sickle cell that certainly include pain, but also exceed pain, the unmet needs in sickle cell disease, what we're doing and how we're using novel therapies in sickle cell, what our current crizanlizumab experience has been here, some of the barriers to care in sickle cell disease, and how important it is that we individualize our care for our patients. We know our individuals are living longer, but we have to help them live longer, stronger, and better. And I'm happy to take any questions. Thank you.
Thank you, Dr. Julie, for this excellent talk. I think you sum up very nicely. this was very interesting because it came up with background illustration of real cases. So the talk was very interesting to everyone. And there are many questions waiting for you, Dr. Julie. So the first question came from Dr. Mukherjee. So he asked, Dr. Julie, excellent presentation. Are you using hydroxyurea for all of your sickle cell disease patients? What's the dose you start, and will the patient comply with high dose?
So that's a really good question. We offer it, is what I would say, to all of our patients. We want everyone to know that it exists and that it's an available option. For adults, we start at lower dose than we do for our kids. We actually find that starting hydroxyurea at too high a dose is more likely to cause our adults to feel sick or to have problems maintaining their blood counts. So most of our adults, we start closer to just 10 mg per kg and then often don't go up higher than 1,000 milligrams total. We do some patients at higher dose, but only those patients that I know are willing to come in monthly for blood counts, because we do see some concern with suppression, especially of platelets in our adults.
Hello?
Yes?
Hello? Hello, can you hear me? Yeah, Julie, can you hear me?
Yes,
Yeah, Dr. Julie, can you hear me?
Yes.
Yeah. I think Dr. Mukherjee, what question was excellently taken up by Dr. Julie. So the second question came from Dr. Day. He asked what infusion-related reaction with crizanlizumab is there, and any recommendation for prophylaxis with antihistamine to avoid infusion-related reaction before giving crizanlizumab. And regarding the thrombotic episodes in daily life of sickle cell disease patients and their routine screening and follow-up in OPDs, this is another question. So the first question is related to the infusion reaction and whether any prophylaxis is needed for that or not.
So that's a great question. And we've seen varied responses across the country, actually. In general, what we see, and I wouldn't say often, but what we have seen in about 1 in 25 to 50 is some pain that is associated with the infusion. Every once in a while, we see somebody with severe pain. What we have found is that when we do stop the infusion, treat the pain, and give Benadryl or other diphenhydramine, antihistamine, and slow down the infusion instead of 30 minutes that we do an hour, that it seems to get much better and they don't have that anymore. Now, I don't prophylax any of our patients because it is such an uncommon problem that I don't want to be having to give all this antihistamine to our patients. So I only do it if someone has a problem. And it's also important, we have seen many community doctors giving steroids prior to the infusion, and we don't want to do that. We have seen more complications if you give steroids ahead of time. I think that people consider it a monoclonal antibody just like every other, so they routinely give steroids, and we don't want to do that.
Another question from Dr. Niranjan, then for this thrombotic episodes, do we need to screen the patient? Routine screening is required in the OPDs or not? Do we do a routine screening?
We don't routinely screen for thrombosis at all. If someone has had a thrombotic event, then we will put them on anticoagulation. And if they've had either 2 lifetime events or 1 unprovoked PE, we will usually put them on a lifetime regimen of anticoagulation, but we don't routinely screen.
Okay, the next question was from Dr. Kaushik Pal. He asked, known case of sickle cell disease, taking hydroxyurea irregularly, having a painful crisis. Complete hemogram showed hemoglobin of 6.5. Do you need to add hydroxyurea and moist oxygen beside painkiller and transfusion?
So one of the things I think that's really important is that we don't give oxygen unless people are actually having a low oxygen. So in previous years, we would use oxygen during crises, and there's no evidence that it actually helps, but it can actually hide when a patient becomes low oxygen or hypoxic. That's important because we want to make sure we recognize it when it happens. We treat all pain crises aggressively with pain medication, and usually with opioids. So we do recommend that. With somebody's hemoglobin is 6.5, it would depend on whether they were making new red cells and what their reticulocyte count was. And if they weren't taking it frequently, then I don't tend to give it to them when they're sick. And if they're not going to take it regularly, I tend to try and stop it, because otherwise they're more likely to do harm.
Yeah, I think this was a very practical question, what we should all know what is to be done in this situation. So another question is from Dr. Akash. What he asked, that what's the dose of hydroxyurea you use when you combine it with crizanlizumab?
So when someone's already on hydroxyurea, I don't stop it or change it when I add crizanlizumab. So I use the same doses I always use. I don't change it. I think combination therapy could be very effective. So I continue to use the same 500, 1,000, sometimes 1,500 milligrams.
So like when crizanlizumab is started in a patient who is already on hydroxyurea, so it's obvious that the patient was getting the maximum dose because patient is not responding, breakthrough crisis is there. So we are going for crizanlizumab. So in that case, if you combine these two drugs, is there any chance that the toxicity of any of these drugs will be increased? No.
So they totally interact. They don't interact. They work differently. And if they're taking hydroxyurea and they still have breakthrough, we actually think by layering crizanlizumab on top, they'll actually have improvements. But if we were to stop the hydroxyurea, they probably have more pain. So we make sure we don't stop it and we add crizanlizumab on top, remembering that hydroxyurea targets really erythropoiesis. So it helps with fetal hemoglobin and it helps with decreasing neutrophils, but crizanlizumab works on the endothelium. So they don't interact and there's no risk of combining them.
Thank you. So the last question is from Dr. Shikha. She asked how to manage patients of sickle beta thalassemia who behave like transfusion dependent anemia even on hydroxyurea and folic acid. So what she wanted to ask is that a sickle beta thalassemia, the patient is on hydroxyurea and even after that the patient was requiring transfusion for that. So how these patients should be managed?
So that's a great question. The first thing to make sure is that they're not on too much hydroxyurea. So you want to make sure that you're not actually decreasing erythropoiesis. Some patients don't tolerate a lot of hydroxyurea. So you want to make sure you hold it and see if that actually helps them make more red cells. That's one thing. Another thing is to check kidneys. When I see a lot of severe anemia, it often is early sign of kidney disease when they have decreased erythropoietin. So some of those patients, I use erythrocyte stimulating agents that helps a lot. In the US, we can now have the option of voxelotor in these patients to see if we can raise their hemoglobin. It also has a variable response and is quite expensive. So it just depends on if insurance covers it. And then if all else fails and patients are symptomatic in their anemia, we consider transfusions. But if patients have a routine hemoglobin of 6 or 6.5, but they're not symptomatic, we don't transfuse for that. It's only if they're having symptomatology.
So unless the patient is in, but if 6.5, if the patient is in crisis, in that case, only transfusion if people recommend, not even that.
Not for crisis. We would only transfuse if they were hypoxic, had acute chest, or had an organ-threatening issue like heart failure or kidney disease.
Okay, Dr. Julie, like I have a question, like is there any way to predict like which patient will respond to hydroxyurea or crizanlizumab?
I wish. I think that's what we need to study, and we're putting together a longitudinal clinical registry so that we hope we can do that, because it's one of the things that's really lacked overall in our community of learning is we don't know these things. We can't even predict who will have which outcome, much less who can respond to which therapy. So that's definitely the next step in what we need to do.
And hydroxyurea is a yield drug and it's a long time tested drug. So what do you think is that like we need a newer drug to replace hydroxyurea? Response rate also was not very bad with hydroxyurea. So why we need this new drug? Like what was in your experience, what was the main problem for which you recommend other drug?
Oh, I think we have lots of problems. I think hydroxyurea is effective, but not for everyone. We really, even in patients I know who are taking it regularly, I don't see that it works for everyone. So that's definitely one thing. Another is that some patients have significant problems taking it. They have, especially nausea is a big problem. and that they don't tolerate it. And I have some patients whose bone marrow just doesn't tolerate it and they drop their blood counts. And then we have patients who don't want their fingernail beds to turn black or their hair to get thin. And so that's another issue. And then of course we have pregnancy related issues as well. So I think there's a lot of things we don't completely know yet about hydroxyurea that makes people nervous, even though it is well tested. We see things like low sperm counts in men that is not always reversible. So I think we needed another option both to improve pain control, but also hydroxyurea is not preventing mortality as much as we need it to. It's certainly improving it, but we're still seeing our patients dying in their 30s, and we have lots of work to do.
Okay, thank you. We have a panel discussion. I think rest of the thing can be discussed there. Before that, we'll take a short break for a short video in between this your talk and the panel discussion. So I'll request the organizer to start the video. So we are back for the panel discussion. So this is a sickle cell disease expert exchange panel discussion. This will be a case-based panel discussion. Myself is the moderator of this discussion. And the experts with us is Dr. Julie Kantar, Dr. Tufan Kanti Dolai, Dr. Siddhartha Shankar Rai, Dr. Shubhranil Baul, and Dr. Ankita Sen. So I welcome all the experts to this session of case-based panel discussion.
Thank you, ma'am.
Thank you, ma'am.
Yeah, I'll just start the session. I'll just share the slides. Yeah.
Yes, ma'am.
It's visible to all of you.
Yes, ma'am.
Yeah. So to start with, this is a sickle cell disease, homozygous sickle cell disease. Hemoglobin percentage was almost normal for a sickle cell. It's 10 gram %. This patient was having frequent painful crisis. This is a 23-year-old female, an acute chest syndrome 1 episode. Her creatinine was elevated, and she has already done a hip replacement for AVM. This patient has severe pain in his knee, hip, and elbow for last 3 days, and multiple episodes of loose stool. Actually, there was a GI infection which has precipitated this crisis for this episode. She was also having fever for 2 days. So my question to Dr. Ankita is that how do you define VOC, like vaso-occlusive crisis? Like any pain will say that this is vaso-occlusive crisis, or pain requiring hospitalization, pain requiring another. We will say that this patient is having VOC. Dr. Ankita, please.
Thank you, ma'am. Good evening, everyone. So, a vaso-occlusive crisis, the definition is not set in stone, and an accurate definition with markers for time or the number of days is mainly to be found in clinical trials. For our purposes, any episode that might require hospitalization or may not require hospitalization may constitute a vaso-occlusive crisis. On an average, it usually lasts for a few days, and more often than not, the patient cannot manage it at home. However, sometimes they can manage it at home. Some of them, like Dr. Cantor explained, some of them really know very much about their own disease. But usually, some sort of treatment is required for a vaso-occlusive crisis.
So as Dr. Ankita said, like there is no clear-cut definition of VOC. Like some of the trials said, when the patient has attended a clinician, then only it will be considered a VOC. And some of the trials said no, any plane can be taken as a VOC. So Dr. Julie, we want, because this is very important thing to know clearly which pain we should consider as VOC. So Dr. Julie, which one you considered as VOC? All pains in a sickle cell patient you consider as VOC?
So we talk a lot about this, and unfortunately the definition is still what a patient tells us it is. So when they say I'm having a crisis, we have to take them at their word. However, we also have more conversation. For example, if this is somebody who has significant avascular necrosis of the hip, we talk about, is this more pain in your hip that's usually there, an exacerbation of your chronic pain, or is it truly a new chronic pain, a new acute pain consistent with a crisis? Some patients have been taught that any pain is a crisis. And so it's important to talk to them and help them understand what's truly acute sickle cell crisis pain versus an exacerbation of chronic pain.
Thank you. This patient was diagnosed at the age of 5 years. The patient had multiple crises by this time, and she was started hydroxyurea at the age of 7 years. And after hydroxyurea, it was interrupted many a time, sometimes because of gastritis, sometimes because of cytopenia, and the patient was not very compliant also. So she was taking hydroxyurea very irregularly, not regularly she was taking. And sometimes the patient was lost in follow-up for some time duration of time. So like Dr. Tufan, like you treat a lot of sickle cell disease patients in your OPD also. So what challenges actually you face with hydroxyurea tolerance and other areas?
Yes, good evening to all of you and Dr. Julie also. So I think this is a very important question in terms of the hydroxyurea tolerance and hydroxyurea adherence, because usually we started the hydroxyurea at the dose of 10 to 15 mg per kg, and gradually we try to escalate depending upon the episode of the VOC. But fortunately, around the two-thirds of the patient, around the 50 to 60% patient, they can able to take the drugs, and the majority of the drugs, they are not taking the drugs. So in my practice, the adherence is around the 50 to 60%, and around the 30 to 40%, they are not taking the drug properly. Another aspect of the hydroxyurea is the tolerance, because some patient we show that a lot of the side effect is there. Particularly, sometimes we get there is the recurrent oral ulcer, there the leg ulcer. Sometimes the GI intolerance is also one of the important issue in terms of the intolerance. And around 30% of the another patient that even after giving the dose of the hydroxyurea of the 20 to 30 mg per kg, the VOC we are unable to control. So there is a lot of challenges for managing the sickle cell disease only with the hydroxyurea. Over to Dr.
Thank you,
Bhupendra.
Dr. Tufan. So we know that it leads to cytopenia, and these are the side effects that has already been discussed by Dr. Tufan. And as Dr. Tufan said in one study that was published last year only, it has shown that around 57% patient discontinued hydroxyurea, and all these are because of adverse effect only. So it's not very easy to continue sickle cell patient with hydroxyurea. But it has been shown in one study that you can see from these graph that this is a pediatric patient who are taking hydroxyurea, maybe because of sickle, maybe because of non-sickle issue. And the graph is increasing since 2009 to 2015. So many patients, many children are actually on hydroxyurea. And we face all this sort of problem with this patient who are on hydroxyurea. Coming back to the patient again. The patient had reported to the hospital 2 years back when she was 21 years old. She already had multiple comorbidities. ABN, I have already told, acute chest syndrome. She had 3 episodes of VOC when she attended hospital 2 years back. That time also she was started hydroxyurea and she didn't continue hydroxyurea. So at this moment, at 23 years, when she has again visited with her problem, when she has visited the clinic again, the patient is 50 kg, hemoglobin is 8.6, WBC count is 10,000, platelet is adequate, and this is the hemoglobin 8%. So Dr. Siddhartha Shankar Rai, so I'd like to ask you, we will initiate hydroxyurea in this patient. This is a patient who has been on hydroxyurea and there was recurrent interruption of hydroxyurea therapy.
So this time, if the patient has come, stopping hydroxyurea for some time, according to the body weight, I would like to start 10 to 15 milligram per kg. So I would start with 500 milligram because it is not available. 750 milligram or some, it's not in tablet, only in capsule it's available. So I will start with 500 milligram one capsule daily, and I will monitor that how the symptoms relieves with that, and also how I will monitor the count, that is for the toxicity. And accordingly, if we find that the patient is tolerating, there is not much toxicity of hydroxyurea and the painful crisis frequency is not decreasing, so I will gradually increase the dose to then one day once, one day twice, then ultimately twice daily. I would go up to 1 gram per day.
Okay, so you'll start with 500 milligram, and if the patient is not responding, like is there, you'll monitor the patient. If there is breakthrough VOC, then of course you want to increase the dose to 20 milligram per kg. And of course, we need to monitor the toxicities. Yeah, Dr. Siddhartha, like CVC, we need to consider before increasing the dose of hydroxyurea, no?
Yes, that's what I will look for the CBC and that is toxicity, and if she tolerates, then only we can think of increasing the dose.
Okay, so that can be increased if the patient is not responding. So, Dr. Shubronil, like we are using hydroxyurea for our patient. You are also using in your clinic hydroxyurea. So, what do you consider as optimal use of hydroxyurea? And when, how many patients you have used, and how many patients you found that this can be used optimal dose of hydroxyurea to your patients? Dr. Shubronil Baul, please. Dr. Shubranil is there or not?
He's mute. He's in mute. Sir, please unmute your line.
Oh, okay, ma'am. Okay, ma'am,
Yeah.
can you hear me? Everybody can hear me? Yeah. So
Yeah.
So considering as an optimal use of hydroxyurea, as of now, we have only in our country we have hydroxyurea, and taking into consideration the uses of hydroxyurea in our patient, we have found a decreased incidence of pain crisis. Definitely, it reduces the pain episodes. It definitely reduces the complications. But actually, to see what are the real tolerance, real side effects of hydroxyurea, which is very common, which is very prominent in the Western countries, the detailed picture in our country is not so clear. And why? When will you consider a case of hydroxyurea failure? We have clear guidelines regarding hydroxy failure in case of regarding this beta thalassemia. But in sickle cell, we don't exactly, I cannot say regarding the Indian scenario when we consider hydroxyurea failure. Rather, when I will find a case with disturbing case of more VOCs with other side effects like leg ulcers, oral ulcers, or a significant decrease in the total count, platelet count, I would consider rather to discontinue hydroxyurea. Thank you, ma'am.
Okay, thank you, Shubhronil. So I'll ask this question, Dr. Julie. So I want to have her opinion also. So Dr. Julie, like when you consider that your patient is not responding to hydroxyurea and you need to change the therapy?
So that's a great question. When I know they've been taking it consistently and continuing, if I've started it for pain crises, continuing to have significant amounts of pain, or when I know they've been taking it consistently, especially in people with SC disease, when you don't see any change in their CBC. Sometimes you don't have enough of a stress erythropoiesis and they don't make fetal hemoglobin, or they don't see a decrease in their white counts. It's a little different in SC disease. So I give it at least 6 months and at least 2 dose increases. And in fact, I give all of the new meds as well, a minimum of 6 months before I would consider them a failure, because it takes a while to see an improvement, and you can need to build up, in the case of Hydrea, the fetal hemoglobin and the decrease in neutropenia or decrease in neutrophils. We do stop hydroxyurea in anybody who has a leg ulcer. I'm not sure that I think it causes leg ulcers, but I do think it helps prevent healing. So I do stop it in those cases.
Thank you, Dr. Julie. So it's a very clear now that when we'll consider that, how long we'll continue, and when we'll consider that we need to change therapy from hydroxyurea to other agents. So this patient was in hospital 2 weeks back also. So on careful discussion, we found that the patient has 2 episodes of crisis lasting for 4 to 6 days, which was managed at home only. She didn't come to a doctor. There was an additional episode of crisis managed by local physician, and there was recurrent crises or recurrent VOC in this patient over past 12 months. So, Dr. Julie, again, a question comes to you. How you monitor your clinical practice, a patient who is on hydroxyurea? How you monitor the patient? Like,
so if they're on hydroxyurea, depending on the patient, we either get blood counts every month or 3 months, depending on their stability. And we do clinic appointments at that same frequency. These days, we do a lot more telehealth, which has been great for us and great for patients. So we do quick check-ins, and we can, at the same time, ask how patients have been feeling. Have they had a lot of recent problems or pain? Have they had to go to an emergency department or been in the hospital? So by checking in at least every 1 to 3 months, we're able to monitor both their blood counts, but also making sure of how they're feeling.
so Dr. Tufan, like we are treating sickle cell disease patient in a different scenario, like socioeconomically, so far as the education status of the patient is concerned. So how you monitor your patient for VOC once you put the patient on hydroxyurea?
Yes, I think this is a very important and also very difficult question to answer, because in terms of the vaso-occlusive crisis, the pain is the one of the important aspects. So for the quantify the pain is also very important, and also the threshold of the pain is varies from the patient to patient. Sometimes we use the visual analog scale for grading the pain. This is the one way we can assess it. The another important thing is that usually in general, if the pain is required the hospitalization, and if the pain require the hospitalization and attention to the physician and the treatment with analgesics, I think this VOC is very, very important. So to monitor the vaso-occlusive crisis in the hospital, not only the pain monitoring, but also the other organ function should be monitored properly, along with the WBC and the platelet count during that point of time. So for optimizing the VOC monitoring, I think it is the very, very difficult questions. And also from the rural area to the tertiary care center, I think this is a lot of difficulty there, the fees.
So Dr. Tufan, are you keeping this kind of charts in your clinic, like to monitor like the patients when they have pain? So categorize the pain like mild, moderate, severe. So do you think that this type of chart should be followed in the clinic?
I think this will be the ideal. We should do that for the monitoring of this, the VOC, particularly the visual analog scale, the duration of the hospitalization and hours, and also the parts of the affected, particularly the illiterate patient. I think this chart is becomes very helpful for managing the patients with sickle cell VOC.
Thank you, Dr. Tufan. So this patient's blood report have already showed creatinine was high. All other reports was okay. So this patient has multiple VOC and creat is already high. So one organ damage is there. So question to Dr. Siddhartha Shankar Rai. Dr. Siddhartha, like, do you think that if a patient is undergoing recurrent attack of VOC, this leads to end organ damage?
Yes, according to the pathophysiology, what is already shown by Dr. Julie, that is clear that every time there is vaso-occlusion, it is actually that it is creating some amount of damage because of the hypoxia, then also hemolysis, then related to the iron and free radicals, all those things that is creating local, not only vascular damage, and also the tissue damage. All so ultimately repeated, and that damage from them, cytokines are being released, which is again that increasing the amount of the inflammation. Again, that will lead to vaso-occlusion. So that vicious cycle sets up, and ultimately that will end up in organ complications and end organ damage.
Thank you, Dr. Siddhartha. So what happened in VOC is that these are acute episodes, but these acute episodes leads to chronic damage to various organs of the body. So Dr. Ankita, like, what are the organs that should be taken care of? Actually, we should monitor the function of what organs. These are the organs that can be damaged by recurrent VOC, and that can lead to morbidity to our sickle cell patients.
Right, ma'am. So basically, sickle cell disease can lead to involvement of any and every organ, but the more for monitoring purposes, regularly we should rule out any retinopathy. We should look at the we should rule out pulmonary hypertension. We should rule out any hepatic involvement, any nephropathy. So both acute and chronic complications will be there. The bones might be involved. There might be avascular necrosis. So overall, every organ can be involved. We should be alert for stroke and neurological complications. So, so overall, everything should be taken into account, and either at regular intervals we should follow up our patient. And of course, any slightest history from the patient, we should go in that direction and monitor the specific organ for damage.
And one important thing is that patient can have recurrent infection also. In a sickle cell patient infection, we often forget about infection in sickle. We give more attention only on crises, but in a pediatric patients group, sickle infection also, I think we should keep in our mind. This may be related to infection. Thank you, Dr. Ankita. So as Dr. Ankita said, we need to monitor the function of various organ like lung, like splenic function, like stroke, in the pulmonary embolism, and these should be monitored regularly as a complications of VOC in all the sickle cell patients. So the list is a long one. I think all the organs are affected, even kidney is affected. The patient we are discussing is having a sickle nephropathy, creatinine is high. So any organ can be affected by recurrent VOC in a sickle cell disease patient. So this patient was non-compliant behavior, frequent painful crises, hydroxyurea failure, because in spite of that, patient was having chest symptoms and ABN and everything. And only thing is that serum creatinine suggests that there is a end organ damage. So there is a sickle-related nephropathy. So Dr. Subramanian, if this patient comes to you with all this type of features, what actually you'd like to opt for best you think for this patient?
Ma'am, regarding the considering this patient who is she is not interested to continue with the hydroxyurea. So what I, and also there is an end organ damage.
Like she is not interested to continue. She is very fussy.
Non-compliant behavior.
Very irregular treatment.
Yes, ma'am. So basically, if I considering the present scenario, I would prefer to counsel for crizanlizumab, basically if it is available. And also very important is that I would also increase his clinical monitoring, because sickle cell is a multisystemic disease, what Dr. Ankita has previously mentioned in just so, because complications are unexpected. And what I have just listened to ma'am, Dr. Julie ma'am's talk regarding the crizanlizumab at a dose of 5 milligram per kg, I would initiate, and it has shown statistical reduction rate of VOCs at 45.3%. And regarding her other issues like decreasing hospital visit, decreasing her painful crisis episodes, will be subsequently clinically monitored.
Do you think the patient who is non-compliant to hydroxyurea will be compliant to crizanlizumab?
Ma'am, hydroxyurea, the patient has to take it daily, ma'am. And with crizanlizumab, there are reduced hospital visits. I think there are doses, weekly doses, then 2 weekly doses. Does not need that she has to come daily. She has to come once only for an infusion weekly once, ma'am. With
So less
very
toxicity, and there is a freedom for activity also. The patient doesn't need to take drug every day. So that is
yes,
a
ma'am. Yes,
important
ma'am.
thing for a patient who is on therapy lifelong hydroxyurea.
Yes,
So
ma'am.
if she needs to comes to hospital once in a week, it's fine. But if she needs to take the drugs every day, then it's difficult for anybody. It's difficult to continue with a drug. So I think these are important thing. Hydroxyurea is a good drug for physician. It acts, but it's not a good drug for the patient. The patients are not very compliant with hydroxyurea. So Dr. Shubhra Nilbaul already said that for this for patient where patients doesn't want to take hydroxyurea or taking hydroxyurea irregularly, where the patient is having regular crisis in spite of hydroxyurea, the only option at present we have is crizanlizumab. So Dr. Subramanian already highlighted the role, but I want to know something from Dr. Julie, like you are the expert, you use crizanlizumab for many patients. So, what is your experience? Like the patient who were non-compliant, they become compliant with crizanlizumab?
Yeah, we've actually had great compliance with crizanlizumab and great adherence. Our biggest problem has been if for any reason a patient misses a dose is that we don't forget to bring them back in and to reschedule them. So trying to keep track of 50 patients has been a little more challenging, and we're looking at new ways to do that.
So this 45% reduction is VOC, practically how it matters, like if there is 45, almost 50, almost half reduction. So what do you think, how it's going to help a patient? It's not that patient will not have any VOC.
Some patients, so we did see in the trial that some people did not have any VOC. That was less common, but it certainly happened. But I mean, the best example, I had one patient who was going to the hospital 12, 14 times a year. And then in 2020, he has only been twice. So significant improvement. So it just depends. And that was someone who did not tolerate hydroxyurea and has never had any issues coming in for that.
Dr. Tufan here. Question
Yeah.
to Dr. Julie, please. So you have enough experience of the crizanlizumab. My question to you is that ideally, which group of the patient the response to the crizanlizumab is good? And another question is that in terms of the adverse effect. So how to select the patient for the crizanlizumab?
So we tend to discuss, all of the options with our patients, but we tend to really focus crizanlizumab on patients who are having frequent acute care visits, often in the hospital, or often coming to the ER. And also patients that we think are modifiable. There's a not large, but there's a group of patients who have other reasons for coming to the hospital or have chronic pain that you're not going to fix. So we want to make sure that they are responsive to the therapy.
So in continuation to Dr. Tufan's query, so Dr. Julie, is there any absolute contraindication for crizanlizumab?
There isn't. Well, that's not true. The only absolute is pregnancy. So at this time, we don't have any data on pregnancy. And so we do not give it to patients who are pregnant. but it is not modified by kidney disease, and so it should be safe in patients regardless of their creatinine because it's not cleared renally. So we otherwise don't hold back.
And any pre-workup before starting crizanlizumab, like these are the things that should be done before putting a patient on crizanlizumab. It's not nothing like that.
Nope,
Okay.
nothing like that.
So
It's
that
really
is a
easy to
freedom for
use.
a doctor also. Yeah.
Yeah.
So we know that it's very effective, and Dr. Julie has demonstrated all these things. I'll not go into the detail. And safety profile also, now Dr. Tufan asked, and he said, and she said these are the side effects, and there is no absolute contraindication, and we don't need to do a pre-workup before starting a patient or before putting a patient on crizanlizumab. So this is a drug which will reduce the incidence of VOC, hospital visit. At the same time, this drug is having less adverse effect, and these adverse effects are mild also. So, and there is no contraindication, and the burden on the doctor also is less because we don't need to do monitor the patient by CBC and other things as we need to do when we put our patient on hydroxyurea. So this is the last slide. So to sum up today's discussion, I first think what was our question, that what should be considered as VOC. So any degree of pain that requires attention, medical attention, should be considered as VOC. And in all sickle patient, we should monitor our VOC. Showed you that there are some charts how you can keep a record of your patients, how many VOCs are there over last months, what are the organs involved, and all that way. Hydroxyurea should be used in patients in case of patients are having VOC, but there are problems with hydroxyurea because many patients are non-compliant and there are adverse effects, so tolerability issue is there. And we need to monitor the patient who is on hydroxyurea, whether there is any failure of hydroxyurea. If there is failure, of course, we'll have to go for a new drug, crizanlizumab. And this drug already has been discussed in details by Dr. Julie, how it works and how it's effective in patients. Dr. Julie, my last question is that, is there any option of putting a patient as a frontline therapy on crizanlizumab?
I think we always recommend hydroxyurea first because the data is stronger. But certainly in patients who haven't tried, who don't want hydroxyurea, we don't not give them crizanlizumab.
So this till now, it cannot be used as a frontline drug. We should start all patients first on hydroxyurea, and if there is any problem, then only we should change it to crizanlizumab. So thank you, Dr. Julie, for enlightening us on this sickle treatment, especially on the new drug. And I thank all my panelists, Dr. Tufan Kanti Dolai, Dr. Siddhartha Shankar Rai, Dr. Shubhranil Baul, Dr. Ankita Singh. So I thank
you, ma'am.
for this beautiful academic session. Thank you all.
Thank you, madam.
So I hand over the session to the organizers.
So, ma'am, if there is no questions from the audience or the panelist,
I think there is one question line here. Okay, I think nothing is left there. Okay.
So if there is no other questions from the panelists, then we can close the session for tonight.
Yeah, I think we have a very good academic fest this evening. And we now by this time we know a little bit of sickle cell, how to manage our sickle cell patient and how to keep them healthy and compliant also. So thank you all. We can now a good night and have a nice dinner at home because of this COVID situation. Thank you all. Good night.
Thank you very much, and good night.
Thank you, sir. Thank you, ma'am. And thank you all the faculties for joining in. Thank you so much.